Hello, I'm Emily Chu from the National Eye Institute. It's my great pleasure to present to you an update on age-related macular degeneration, or AMD. AMD is the leading cause of visual impairment in the white population in the United States. It ranks third in the global cause of vision impairment. Globally, it accounts for 9% of all blindness, and by 2040, will increase up to 288 million people affected. Risk factors include aging, smoking, education, nutrition, and genetics. I will address some of these factors in my presentation. In the United States, approximately 2 million people are affected with vision-threatening stages of macular degeneration, and approximately 8 million are at high risk for developing this late AMD that causes vision loss. The treatments are onerous for both in resource and time for the affected individuals and also for their families. There is associated monetary and emotional burden on the family and society. This is a graph showing AMD throughout the world. Framingham and Beaver Dam come from the United States, Rotterdam come from the Netherlands, Blue Mountains in Australia, Euro-Eye is from Europe, Beijing is from China, Barbados, and the Japanese and Indian studies are also shown here. As you can see, the x-axis shows increasing age, and by 75% of age, this takes off. So late AMD increases with age. So aging is one of the major risk factors. We also know smoking is very important. The more you smoke, the more likely you are to have AMD. This shows that the most smoking, 40 packs per year, there's a 5-fold increased risk of having AMD. This is a patient's perspective showing what happens. People with early AMD or patients with AMD actually may not have any symptoms at all. And they can see it quite clearly, but with time, they develop a central blind spot. This blind spot really affects their ability to recognize faces. One of the most common things I hear from my patients. Obviously, they can't drive or read. Let's have an anatomy lesson of the eye. Coming from the front of the eye, the cornea is at the watch glass, it's nice and clear. Iris is what gives you the color, brown or blue eyes. And lens is what becomes a cataract. The sclera is a white part of the eye that really is, protects the whole eye. And the retina lines the back of the eye. It's a very thin tissue that's connected to the brain through the optic nerve. The macula is where you see best. The optic nerve is really the collection of all the fibers coming in from the retina, and we see with our brain. If you have problems with the brain, such as a stroke, if there's a stroke, you could actually have vision problems as well. This is what we see as ophthalmologists when we look in. We dilate your eyes. The macula is the very center part of the eye. That's where the best 20/20 vision comes from. That's the real estate we have to protect the most. Optic nerve is again where the white circle, which shows the nerve fibers going into the brain. Macular degeneration is characterized by having these little small yellow flecks called drusen. The small ones are found in early AMD, and the larger ones are found in intermediate AMD. So the more extensive and more larger they are, the more likely you have more severe AMD. This is the late stages that are vision threatening. I've labeled the blood one sees in the wet form of macular degeneration. The dry type is this slow, drying, withering away of the tissues. There's no effective therapy at all for dry AMD at this point. So dry is diagnosed by your ophthalmologist usually because you have good vision. The central retina has acquired abnormal drusen, and lately becomes distorted and pigmented and thin as a result. This occurs very slowly and of any progression to vision loss. The wet form are abnormal blood vessels I showed you in the picture previously develop under the retina and that leak fluid, blood, and fats. This course can lead rapidly to central vision loss due to bleeding and, of course, the scarring. This is an Amsler Grid that often you're given to evaluate. And how to use an Amsler Grid. So you cover one eye. So you're doing it monocularly, one eye at a time. You look at the dot. And while keeping your eye on the dot, you concentrate on the lines which cross over the rest of the box. If these lines are straight and relaxed, because you can just repeat this because that eye's fine, relax and repeat this on the fellow eye. However, if there's lines missing or bent, then you should contact your eye physician to let them know that things have changed. And you may have certain changes that are yours that are the same. If they remain the same, your doctor knows about them. It's those changes that become more important. We also suggested a home monitoring device, which is covered by Medicare, and you check one eye at a time. And we proved that this device can help detect early wet AMD before it gets worse. And this indeed is an important equipment to consider. You will get an alert from this if things are changed, and you will let the doctor know. And this is a way of picking it up early. And this is supposed to be done on a daily basis. Now, this is a timeline of development of all the AMD treatments that we have used in the past. If you remember, in 1982, we had hot laser, which was the best we could do at the time, but recurrences came back and really didn't improve vision at all. In fact, and sometimes made it worse. Photodynamic therapy was the next thing in 1999, and again, it was the best we had at the time. A drug was injected into your veins. We applied a cold laser to the eye, and that reduced the risk of some vision loss. However, there was also recurrences, and it caused some very severe changes in the end. AREDS supplements, I'm going to talk about that in the future, in our presentation rather. And of course, we have incredible change by 2006 for the wet form macular degeneration when the anti-VEGF therapies, these are drugs that are injected into the eye, the Lucentis or Eylea or Avastin that's injected in the eye, that has revolutionized how we treat people with wet AMD. Patients now have stable vision. They can actually improve by 40%. So this really is a game changer. But we still have lots to learn still about this treatment. And finally, in AREDS 2 in 2012 rather. We started 2012 and we finished in 2016. So we had a National Health and Nutrition Exam survey, which is done every few years to survey how well we eat, what's the state of the status of the health of our nation. In 1988, investigators found that people who ate rich in fruits and vegetables with vitamin A and C had a less AMD. In other words, the more you eat, the less likely you are to have macular degeneration. So these seem to be protecting patients from getting macular degeneration. The AREDS study, the age-related eye disease study, was started as a natural history study to see what we can learn from the natural course. But we had a clinical trial. We actually tested some vitamins and some minerals to see if it would reduce the risk of macular degeneration. In 2001 to 2005, we then followed the patients without the trial. We already finished the trial, and we want to see the long-term effects of this disease. So we tested vitamin C, vitamin E, and beta-carotene, 500 milligrams of C, 400 internationals of E, and beta-carotene, 50 milligrams. These are large doses. And we also tested zinc. We found that the combination of the vitamins and zinc resulted in 25% reduction in the risk of progression to late AMD in 5 years. And again, at 10 years, even though the randomized trial was finished, we're still seeing an effect 10 years later. Who should be taking the AREDS formulation? These include patients with intermediate AMD, those people with the large drusen that your doctor can identify. Patients with late AMD in one eye, you've lost vision in one eye, you probably have intermediate in the other eye as well. It's not for current smokers because 2 other studies at NIH done at the same time show that beta-carotene increases the risk of lung cancer in smokers in these 2 large trials. And it's not for unaffected children of individuals with AMD. Children whose parents have AMD often ask me, should I be taking this? My answer is, go get an eye exam. If you have intermediate AMD, then you should start on this. If not, don't take it because it doesn't work for any earlier disease. So the public health impact of this was quite enormous. We calculated that 300,000 people would be safe from getting late AMD and losing vision over a period of 5 years if they took the AREDS supplement. So this is the timeline. In 2006, we started AREDS 2. And why did we do that? That's because in AREDS 1, we found that people eating lots of green leafy vegetables or food containing omega-3 fatty acids, such as fish, and these are so-called fish oils, that these high dietary intake of green leafy vegetables and fish were found to be associated with less AMD. And we tested this by adding lutein, zeaxanthin, and omega-3 to the original AREDS supplement. And these want to know if these two factors had any effect on it. And we included patients who were at higher risk of macular degeneration than those in AREDS 1, so they had to be large drusen or had late AMD in one eye. Well, to really our disappointment, the fish oil did not work. Omega-3 fatty acids made no difference. Lutein zeaxanthin did have an increase in benefits. This was especially so in patients who did not eat any lutein zeaxanthin. In the dietary questionnaires that we did, the people who ate the least or none, they had 25% improvement over that. And whenever we compare lutein to beta carotene, lutein always won out, was always better than beta carotene. But what was more important was the fact that, remember, beta carotene increased the risk of lung cancer. In this case, in our study, we found, again, beta carotene doubled the risk of lung cancer compared to using lutein. 90% of these were former smokers. They weren't even smoking at the time, but you're still at risk for lung cancer. So for safety concerns, we found that it was safer, and lutein zeaxanthin could be safer than beta carotene and was also more beneficial. So we replaced this. And in AREDS 2 supplement, we eliminated beta carotene, added lutein and zeaxanthin. Mediterranean diet is something you're probably well aware of, and is certainly seen a lot in the press. Many decades ago, cardiologists were very interested in people living in Crete because they had a much lower rate of dying from cardiovascular disease. And they opined that perhaps it was the Mediterranean diet that was important. So more recently, in the last decade, there was a randomized trial conducted in Spain, and they found that Mediterranean diet was beneficial in reducing cardiovascular disease by as much as 30%. So risk of heart attack, strokes, etc., were reduced by 30%. What is the Mediterranean diet? Well, it includes high consumption of fruits, vegetables, nuts, legumes, whole grains, low on red meat, moderate on fish, and taking more monounsaturated fatty acids, and so on. The AREDS and AREDS 2 studies actually asked the patient at baseline to give a self-report of dietary intake in the past year. We used this data to calculate who had what degree of Mediterranean diet. Did they have mild amount, a moderate amount, or high amount of Mediterranean diet? We had nearly 7,756 patients who did not have late AMD at baseline. And we found that there was a reduction in those who ate the highest level of Mediterranean diet for both the dry and wet type of AMD, and both the late AMD, both types. So the high intake of Mediterranean diet was associated with a decreased risk of progression to late AMD in both forms. Which component was important? We wanted to know that question, the answer to this question, and we found it was fish. So eating fish twice a week had the 31% decreased risk of progression to dry AMD. So eating fish was perhaps the most important component, and that's twice a week. That could be tuna fish, it could be salmon. And what if you have early AMD? And we measured what's the rate of developing the large drusen, which is sort of the intermediate stage, the next stage. We found again there was a reduction by 25% by taking higher intake of Mediterranean diet. So high adherence to Mediterranean diet was associated with decreased risk of progression from early to intermediate AMD. So Mediterranean diet is pretty good. It decreases progression to late AMD in those with intermediate AMD, and also progression to large drusen in those with early AMD. So it appears to be important in both early and late and intermediate AMD, so it's never too late to start a Mediterranean diet. Let's talk about cognitive function for a minute here. Alzheimer's affects 46 million people worldwide and 5.2 in the US, and it's going to triple, or rather, triple in the next 4 decades. So we've looked at omega-3s and found that it was not effective in reducing cognitive function impairment. We again looked at the Mediterranean diet, and we know other literature suggests that this was important. And here you see that highest intake of Mediterranean diet had as much as a 63% reduction in one of the tests for cognitive function. So this indeed suggests that Mediterranean diet may be very important also in cognition. Again, we looked at different components, and we found that the fish was very important, and this resulted in almost a 64% reduction in the risk of cognitive impairment in the patients studied in AREDS. So the closer adherence to Mediterranean diet was associated with lower risk of cognitive impairment. And again, the component of fish was associated with a decreased risk of cognitive impairment. Taking fish oils was not beneficial for preventing decrease in cognitive function. Let's address genetics of AMD. Genetics is a very complex genetic disease. It's not like Down syndrome where you have one gene that's involved. It's multiple genes. It's 52 areas of 34 specific genes. Also, AMD can be modulated or affected by diet and smoking, as I showed you already. So certain genes can also protect you, while some may be harmful. So it's a very complex way of evaluating this. So why do we even study genetics? Well, it could help us understand the underlying disease mechanism. So we know how it works, what's the cause, can we better treat it that way? And can genes actually predict AMD progression? And do genes make a difference? If you have certain genes, do you respond differently because you take the AREDS supplement or the anti-VEGF therapies? Well, the answer is no, it doesn't really help. We find it's best to examine the eyes. These findings predict how the patient will progress much further than genes will. Genetics do not predict response to treatment, and it points to the importance of an eye exam. Genetics testing is important in research, so less so in clinical application. And our professional societies, such as the American Academy of Ophthalmology, does not recommend genetic testing in AMD. So in summary, AREDS 2 formulation is recommended for patients with intermediate AMD, early dry AMD, or late AMD in one eye. Genetic testing is encouraged for research purpose, but not for clinical care yet. The importance of Mediterranean diet and fish for AMD and cognitive function may be beneficial for those with early and even intermediate AMD. And remember, we are what we eat. What does the future hold for us? Well, we'd like to understand some of the functional changes that occur, like adapting to a dark environment, etc. Finding longer lasting drugs for wet form of AMD would be really beneficial for our physicians and really mostly for our patients. Finding an effective therapy for treatment of dry AMD form is paramount to really helping patients with AMD. Both the late form and also for preventing the drusen to progressing to more severe AMD would also be very beneficial. Stem cell work is being done and evaluated even at the National Eye Institute, but it's still highly experimental. We don't have any conclusions from that. But certainly the future is bright. We're going to be working towards finding more treatments for macular degeneration. Thank you very much for your attention. I would like to also thank my AREDS investigators, who AREDS 1 and AREDS 2, there were just thousands of people involved who helped us with this, and the thousands and thousands of patients who helped us and participated in our study and giving us 10 years of their time, which we're forever grateful for. Thank you again for your attention.